I used to think a heart attack looked something like this.
Man, my chest really hurts.
I later learned it looks a little something like this instead.
Man, my chest really hurts. I should probably go to the hospital.
A heart attack, put simply, is when the heart is suddenly not getting enough oxygen. This leads to gradual suffocation and death of the heart cells, causing chest pain. Untreated, it may eventually cause death, though this process is a bit slower than in the movies. But what is actually happening in the artery to cause this to happen? Why are some people at higher risk than others? I have here a model of a healthy coronary artery. Notice how open and clean it is. The blood flows very well through this. Now, a person at a higher risk of a heart attack likely has something like this going on. This right here is called an atheroma, which is essentially just a plaque of fat that is clung to the wall of the artery. These plaques tend to get bigger over time, especially in people with high blood cholesterol, which essentially just means they have more fat floating around their blood. When the plaque is small, blood flow is generally well maintained, you likely don't notice any symptoms. At larger sizes, blood flow can start to become impacted, and you might notice some chest pain on an exertion at this point, also known as angina. But what really causes a heart attack is when this plaque ruptures. This leads to the fatty deposit inside of the plaque being exposed to the blood, and your blood does not like this. Your blood sees this ruptured plaque in the same way as any other wound, and tries to fix it in the only way it knows how, which is by building a clot. If the plaque is small, this is fine, and you might not notice anything, though, if your plaque is advanced, like this one, you'll notice that the clot can lead to a critical narrowing of the artery, and this leads to minimal blood flow, or no blood flow in the heart past this blockage. This lack of blood flow leads to gradual tissue death, also known as necrosis, and this necrosis can eventually lead to death if not resolved quickly. So how do we resolve it? When we have a model showing blatant necrosis of the heart, it's easy to diagnose a heart attack, but medicine isn't that simple. For one, you can't see the heart when you're assessing somebody, and if you do, then you've probably got another issue entirely. You may think of a heart attack presenting with central crushing chest pain spreading down the arm and up into the jaw, but that's not how it always presents. Some people have no chest pain at all, instead just experiencing nausea or abdominal pain, and this can make it a lot more challenging for a doctor to diagnose. So you may wonder, how do we know it's a heart attack? Well, there's a couple tests we can do. The first one's an ECG, though this isn't perfect. This here's a normal ECG. You can see the P, QRS, and T wave. Depending on when the heart attack first came on, we could see some changes, particularly in this segment here. This finding is called ST elevation. It sounds technical, but it's probably the most unoriginal name you could give this thing. There's literally elevation between the S and the T waves, ST elevation. While this finding is a very good sign of an ongoing heart attack, it's not perfect. You see, heart attacks with ST elevation are only one of the two types of heart attacks you could be having, and we would be missing a lot of heart attacks if we didn't account for this, which you obviously don't want to be doing. Heart attacks are also known as myocardial infarctions, which is a mouthful, so doctors typically say MI for short. When there's this ECG finding, ST elevation, we call an ST elevation myocardial infarction, or STEMI for short. But there's another type of heart attack, another unoriginal name, an NSTEMI, or a non-ST elevation myocardial infarction. This is a heart attack where the finding of ST elevation is not present on an ECG. Generally, there's a bit less of a blockage compared to a STEMI, though this blockage is still there nonetheless and is causing damage much the same, just a bit slower. So you may wonder, how do we know if someone's having this type of heart attack? And that's where blood tests come in. So this here is your circulatory system. Think of all the blood flowing around your body in one big cycle. The blood contains a variety of chemicals and proteins, and one of these proteins that may be floating around is called troponin. This can be found in the blood at very low levels, but it's released en masse when the heart is damaged. This test is very sensitive for heart damage, but it's not entirely specific to a heart attack. Patients, for example, with pre-existing heart failure might have naturally high troponin because their heart's always struggling. So what doctors will do is they'll take repeated levels of this protein over a period of time to confirm that acute damage is taking place. So if I just take some troponins now, perfect, and we'll come back in about 3 hours time.
3 hours later.
Hello again. Okay, we're going to jump back in and take a bit more. And let's have a look. Oh yeah, wow, yeah, you certainly have something going on. So you've seen how we diagnose a heart attack. Now how do we treat it? Well, aside from blood thinning medications to prevent the clot getting even bigger, if caught early enough, we may do a procedure called percutaneous coronary intervention, or PCI. This is essentially just expanding the coronary artery to restore blood flow. In this procedure, we'll go through the skin and into an artery, and then we'll feed it up into the affected coronary artery. We feed the stent through the narrowest section of the coronary artery and inflate the balloon. And then after that, we deflate the balloon. What's left behind is a metallic stent, which essentially just acts as a support to keep the artery patent. After this procedure, blood flow is restored to the starved portion of the heart. This return of blood flow terminates any further damage being done, though it doesn't fix any of the permanent damage that might have been caused. For this reason, like in all severe conditions, prevention is better than cure. We typically start patients on a variety of medications to prevent further clots from forming, especially after a stent insertion. We may start them on medications to dilate the blood vessels, or we provide medications to lower the amount of fat in the bloodstream and prevent further plaques from developing. Well, that concludes this video. If you enjoyed it, like and subscribe. There's a variety of videos in the works, so if you're interested, stay tuned for more. If there's any particular topics you'd like me to cover in the future, let me know in the comments, and I'll see you all next time. Thank you.